Assalamu alaikum and good morning, everyone. Thank you very much for joining us for the Grand Downs this morning. Just a humble request to all of you. Please keep your mics muted. We are going to be inviting questions towards the end of the session. A recording of the session will be made available on the Maroof International Hospital social media pages. Hello.
Frozen shoulder certificate.
Sorry, who is this?
I would have thought that we could mute all of them and then maybe open it after the presentation.
Yeah.
That may work more smoothly, I think.
Okay, so the topic today is diagnosis and management of frozen shoulder. And I'm very glad to introduce to you Dr. Mustafa Javed Bhalli. Dr. Mustafa is an internationally accredited surgeon with a FRCS degree in trauma and orthopedics from the Royal College of Surgeons, UK. He obtained his certification of completion of training from the very prestigious Yorkshire Orthopaedics Rotation Program. Following that, he has been a full-time orthopedic consultant in the NHS UK and has over 16 years training overseas. Currently, Dr. Mustafa is working with us here in Maroof International Hospital. He's very passionate about medical education and has been associated with various academic activities, both locally and internationally. I'm sure we're going to learn a lot of things about this fairly common condition, frozen shoulder, today. And so without any further delay, I am going to turn it over to Dr. Mustafa.
Thank you very much, Dr. Shamail, for the introduction. I'll get right into it. I was made aware that there may be physicians from the community joining us as well, though I'll try to match the information level for a more general audience. I've got some disclosures, no potential conflict of interest. I do use orthopedic implants from various companies, including Arthrex, and the equipment will be shown in this presentation. And there are some pictures from the Mayo Foundation, but I was a visiting fellow there. We'll get into a definition. First time this was picked up by Nevaiser in 45, where he termed it as the periarthritis of the shoulder, which means that there's inflammation around the joint in itself as opposed to inside it. And by 1975, we got a term or a definition that we've been using ever since, which is frozen shoulder is a condition of uncertain cause. That's the most important bit, but characterized by spontaneous onset of pain with significant reduction of both active and passive ranges of movement. The etiology, however, still remains unknown. We've ended up classifying as primary, and that means that we really don't know why this happens. It may be related to either conditions that reduce the blood supply to various parts of the body, which includes diabetes, thyroid, and epilepsy. We've seen it related to surgeries of the heart, breast, and neck, and also with stroke. And it could also be because of the fact that there's something else going on in the shoulder, like a rotator cuff injury, the long head of biceps injury, or tendinitis or calcific tendinitis of the muscles, the rotator cuff muscles. And it can also be seen post-operatively following surgery around and about the shoulder. So what it tells you is that we can classify it however we want. It ends up actually being a symptom related to any other condition around and about the shoulder. What we found is that it's a thickened, contracted capsule with synovitis all around. We've also found that it starts at the coracohumeral ligament. That's the ligament, which is also the part of the capsule itself, which joins the coracoid to the humerus. Initially, we thought that it started at the subdeltoid bursa, and De Palma was the one who started telling us that it started where the long head of bicep attaches to the labrum on the glenoid. But what we're trying to tell you is that if you look at the circle, that's where at the front of the shoulder is where the patient points at when they talk about pain. So these are all the areas, or the confluence of all these areas, where you'll find most of the pathology. Like I said, the capsule is a confluence of various ligaments, and the structures that we're involved are and interested in are the inferior glenohumeral ligament and the coracohumeral ligament. And from there, progressively, all the interval structures, the capsules, and all the musculature and tissues around the shoulder get affected as the stage progresses. What we find is a gradual onset of pain. That's what the patient comes in with, and they relate to some form of minor injury, generally putting on a coat, lifting the blanket, opening or closing the curtains of the room. They may also complain of numbness going down the arm with some shoulder blade pain and the back of the neck around the trapezial and cervical area. Initially, we may not find anything wrong when we pick these frozen shoulder patients early, apart from the imbalanced shoulder, that when they lift their arm, their shoulder blade moves in a different fashion as opposed to what we're normally used to. They do complain of some pain in the front of the shoulder, and that's the rotator interval between the supraspinatus and the subscapularis muscles. The global restriction of movements may not be limited in the early phases of frozen shoulder. We do find signs, other signs in the shoulder, such as impingement sign and the biceps anchor sign, which is positive. I think because of the fact that we've got some physicians from the community, I think the earliest way to pick up on a frozen shoulder when you're not quite sure is what we call the, excuse me, I'll just go back if I can, is the inferior glide test. What we're trying to do is we hold the arm up and we drive the elbow into the glenohumeral ligament. And this is shown to be high 90, 100% sensitivity for adhesive capsulitis. Now I'm going to show you a video of a colleague of ours who's had an open humerus fracture surgery twice with myself, and his arm and elbow is doing fine, but he started complaining of pain very early. I'm hoping that you heard the video and saw that. What we end up finding is that this becomes extremely sensitive, and I know now that he's developing frozen shoulder, and probably because of the surgery that has been done on him, and I can pick it up and start early with the treatment plan with him. Adhesive capsulitis generally doesn't show up much on imaging. We do tend to suggest that if these are being referred to myself or a specialist shoulder surgeon, is to get an X-ray done, because pain and global restriction of ranges of movement in the shoulder can also be related to arthritis. So the shoulder joint, the X-rays are to see whether the patient has arthritis or not. If we are requesting an MRI, I would request and suggest to do it with contrast, because the contrast, IV contrast, travels and flows through the shoulder joint. And if there are any leaks, we can pick up on rotator cuff tears or labral tears as well. But what we notice is that the inferior capsule in a normal shoulder joint is capacious, and the dye fills in and stays there. But in a contracted capsule, that space is obliterated, as you can see in the image on the right. There have been phases that have been discussed with Nevaiser where we find the pre-adhesive capsulitis on arthroscopy. And this is what we see on the first picture. It's a long head of biceps traveling up and hypertrophic synovitis, which is quite angry and inflamed looking, but not quite there as yet. But we do see these with patients who've had rotator cuff tears that we go in and repair. The acute phase is, it's widespread. It spreads all across the shoulder, superiorly, anteriorly, and inferiorly. At chronic stages, you start seeing scarring and sclerosis and whitening to a stage where it's matured to a leathery architecture inside the shoulder during an arthroscopic evaluation. Initial management, as been described, and I've got some research to share with yourselves, is to show that steroid injection remains the mainstay, physical therapy, medications. It says that non-steroidals are ineffective, and oral steroids have been shown to improve pain. I do not use steroids, never have. The non-steroidals have been used for associated conditions where we've got calcific tendinitis or inflammation of the tendons that I'm treating. Since 2014, I've been following this Cochrane database where we've had 32 trials on, close to 2,000 patients, and we found that the steroid injection definitely effective in decreasing pain scores. They found that you can refer to the physiotherapists who are here, but home exercises are good enough. They say non-steroidals have no effect. Oral steroids have a subjective effectiveness in improving well-being that we found if we go through the details and discussions is that patients who knew that they were on steroids generally felt better because they were on steroids. And we've had another systematic review who's ended up showing that you've got 92% patient improvement with injections. However, whatever treatment was done at 2 years, all patients showed increased motions and decreased pain regardless of treatment. I take that with a pinch of salt because 2 years is a long time for patients who've got a quality of life to manage, as well as activities of daily living. I'll just go through these simple exercises quickly if you can hear those, and you can share these with your patients as well for them to do at home.
को आप साथ से पकड़ेंगे, कमर के अंदर सेट करो, एक तरफ पुल करने की कोशिश करेंगे, एक्सरसाइज आप 3 सेट्स कर सकते हैं, तौलिए से आप यही चीज आपने दूसरी साइड से जिस कंधे में नहीं फिर दूसरा कंधा ऊपर से
हम की भी कर दी लाल इस कैचअप फ्लावर को है
एवरी टाइम आप ज़्यादा करते चले जाएंगे तो आप स्ट्रेचिंग मेरी सजेशन ये है कि आपको इंजेक्शन अभी लगा है तो आप 2-4 दिन इसके लिए वेट कर लें, जब आपकी पेन सबसाइड कर जाए, मेडिसिन 2 वीक साथ में और उसको आप करते चले जाएं 3 to 5 times a day, 3 to 5 times a day, 3 exercises, simple. Thank you.
Right. So the other option includes what we call hydrodistension. This is a technique where we instill large volumes of saline and steroid or local anesthetic into the glenohumeral joint under image guidance, which could be either ultrasound guided or fluoroscopy. We found that this reports short-term benefits to patients, and certainly a meta-analysis done in 2018. I've not done hydrodistension since 2015, and it has shown that it doesn't matter how much solution has been injected into the shoulder to rupture the capsule. It just did not have that clinical effect that we were wanting out of it. And a steroid shot into the glenohumeral joint is good enough. So I've stopped doing hydrodistension or hydrodilatation. Despite us treating 92 to 95% of our patients successfully with steroid injections, there are always a 5 to 10% chance that these patients may not achieve the desired outcome with non-operative management. And if it's very severe, if the symptoms are bad, where they can't get enough sleep, their activities of daily living are affected, and their work-life balance is affected, then that means we need to move on to a surgical option. The surgical option that has been going on for a while now is manipulation under anesthetic. The patient goes under general anesthetic, and the shoulder is taken through various ranges of movement and stretched out, essentially to tear the capsule on the inside. And that is generally done if 3 to 6 months of physiotherapy hasn't helped. We found quite a lot of side effects and risks with those, especially with recurrence of symptoms. We found a 50% failure rate in diabetics where because they were prone or had the tendency to have frozen shoulder, the condition has come back as well. And especially after post-surgical, if we've done repairs into the shoulder, we do not recommend doing a manipulation under anesthetic, which is a blind procedure. We don't know what we've done or whether or not we've compromised the rotator cuff or biceps anchor repair. Risks include about 10% of fractures. Certainly one of my colleagues in a different part of the on the planet has had a fracture. We routinely see axillary nerve stretches, which gives them pain, which makes them stop doing physiotherapy after the MUA, and then they go back into adhesive capsulitis. And we have reported dislocations as well. So I've increasingly stopped doing manipulation under anesthetic. I do that, but I do add arthroscopic capsular release to it. I'll just go through a short video just to explain things. I may speed up this video if I felt it was going too long.
Dr. Mustafa, could you please increase the volume a bit?
Oh,
if you
sure.
can?
Sure. Does that sound better?
Yes, that's much better. Thank you.
झिल्ली को छील दिया है या उसको टेयर कर दिए और देखें कि मूवमेंट करीब नॉर्मल आती है, लेकिन आई फील कि दिस इज नॉट इनफ। अब हमें अंदर से जाके जो भी इनकी इन्फ्लेमेशन वगैरह जो झिल्ली जो गाढ़ी हुई है उसको शेव करना और क्लीन करना जरूरी है। और इम्पॉर्टेंट ये भी है कि शोल्डर के नीचे वाली जगह जहाँ हड्डी बड़ी भी होती है उसकी वजह से भी फ्रोजन शोल्डर। ये आपका कंधे का अंदर का हिस्सा है, ये आगे आप ये देखें ये फ्रंट का आपका मसल है जो बिल्कुल ठीक है, लेकिन आप देखें जगह कितनी टाइट है और ऊपर ही आपका बाइसेप का मसल है। असल मसला आपका फ्रोजन शोल्डर का ये जो आप सारी लाली देख रही हैं जिसको हमने साफ करना होगा। अगर हम आगे आपका मसल देखें ऊपर तो बिल्कुल ठीक है, नीचे जो हड्डी है बाजू की वो बिल्कुल ठीक है और ये जो शोल्डर है आपका बिल्कुल ठीक है। यहाँ पे असल प्रॉब्लम ये सारी ये जो आपकी सूजन है ये देखें लाली सारी की सारी ये हमने अभी क्लियर की है मजीद और अभी हम इसको और क्लियर करें। दूसरा आपका नीचे तक ये देखना ये जो आपका सारा हमने ये सारा मसला ये सारी लाली जो है ये हम इसको अब साथ साथ क्लियर करेंगे और यही जो कैप्सूल थी सारी की सारी फंसी है। ठीक है, इसको हम अभी साफ करेंगे आपके लिए और मुझे बता देंगे वीडियो बना रहे हैं और इसके बीच में बिल्कुल ये देखें बिल्कुल फंसा वैसा। तो अब ये मैं सारी की सारी जो फ्रोजन शोल्डर का जो एलिमेंट है वो मैं सारा का सारा क्लियर झिल्ली क्लियर कर दी है यहाँ तक के कि आपकी फ्रंट से हड्डी नजर आ रही है, यानी कि आपको मोबाइल होने में कोई इशू नहीं होगा। इंशाल्लाह हम जब आप रेडी होंगे डिस्चार्ज के लिए तो आपकी स्लिंग हम जितनी जल्दी हो सके उतारेंगे ताकि आप ये एक्सरसाइज शुरू करें ताकि झिल्ली फिर से ना पड़े। अब आपकी शोल्डर ब्लेड की जो बोन है ये देखिए ये रगड़ यहाँ पे खा रही है और वो बिल्कुल ठीक। ये एक मेन वजह है जिसकी वजह से आपको ये तकलीफ या फ्रोजन शोल्डर हुआ है। इसको अभी हम शेव करेंगे आर्थ्रेक्स के शेवर ब्लेड से और बॉन्ड से और फिर मैं आपको एक नेक्स्ट आर्थ्रेक्स वालों का आरएफ अब्लेटर है, वेरी यूजफुल शोल्डर सर्जरी में। क्योंकि what it does is ये देख रहे हैं कि tight ligament है, it helps me clearing this ligament. और साथ साथ जो भी bleeding होती है वो भी उस bleeding को control करता है. मेरे लिए view इससे बहुत बेहतर हो जाता है और क्योंकि bleeding भी नहीं होती और ये बहुत इसका trauma या injury to the shoulder सबसे कम. एक बहुत बड़ा पीस है हड्डी का. ये देखिए ये वाला पीस इतना शार्प है जिसकी वजह से आपको फ्रोजन शोल्डर हो रहा था क्योंकि उसने इस एरिया को इतना खुरदरा कर दिया था जिसको भी मैं साथ साथ क्लियर करके आपको दिखा रहा हूँ. और मैंने एक बार फिर से कंफर्म कर लिया है कि आपका टेंडन बिल्कुल ठीक है. यहाँ तक बिल्कुल प्रिस्टीन और बिल्कुल सही. अब हमारा फाइनल स्टेप रह गया है कि हम इस पीस ऑफ बोन को शेव कर दें. आर्थ्रेक्स का 4 मिलीमीटर का सॉफ्ट टिश्यू शेवर इसके लिए यूज करते हैं. इसमें हम सॉफ्ट टिश्यू भी कर सकते हैं शेव और साथ साथ बोन को भी शेव कर सकते हैं. इसकी रेफरेंस भी बढ़ सकती है. इसकी रेफरेंस
Right. So we got some results. We found Harriman was the one who credited with the development of this technique. And I've followed these since 2014, and we found that arthroscopic capsule release showed that within 3 months or so, most patients would have gotten back to their full ranges of movement. And Mehta was credited with the research where he found that 90% of non-diabetics and at least 70% of diabetics obtained full motion with capsular release. There is recommended reading. It's a busy slide, but if anybody was interested, I can share these with them personally, which includes meta-analyses as well as relevant comparative studies on the procedure. And JP Warner, who's been writing quite a lot for adhesive capsulitis for the last 3 decades or so. Conclusions include that the etiology of adhesive capsulitis remains poorly understood. Diagnosis by inferior glide test is effective, especially in early phases. And if it needs to be referred on to the secondary care or hospitals, this is a good test to have done. I would recommend getting at least 2 views of the x-rays to rule out other diagnoses such as arthritis or dislocations. And if we were getting an MRI or was being referred to with an MRI, I would recommend that is done by a contrast. Steroid injections and medications still remain the mainstay of non-operative treatment. Manipulation under anesthetic can work, and it's been carried on across the world, but I would recommend that for non-diabetic idiopathic cases. Arthroscopic release provides best results in diabetics as well as post-operative cases. And if you needed our details, and if you were stuck with patients who weren't getting better following frozen shoulder treatment, we'd be more than happy to see you. And thank you, and I'm open to questions.
Thank you very much, Dr. Mustafa. That was really informative. So we're going to open the session up for the question and answers. You can write it in the chat box if you have any questions, or you can just raise up your hands.
Thank you, Dr. Mustafa, for a very wonderful talk. I have one question. How many patients do you think alone opt to go for just physiotherapy and not injections, and how do they respond to just physio?
Yeah, I think that's an excellent question, because there is always that fear element as to what, because steroids have had a bad publicity for one reason or the other out in the community. And yes, many people may essentially not prefer to have physiotherapy done. So the basic answer to that is to have a long chat with the patient, to explain to them that yes, you can start with physiotherapy if you've counseled them well, and say there's no harm in starting physiotherapy. Do remember that it may be painful whilst you do it. And if at some point you are not progressing according to your physiotherapist's pace, or you're getting worse, or you're getting pain because of physiotherapy, steroid shot would be a good idea for you. It's a pain relieving measure, reduces inflammation, and you can get back to physiotherapy much quicker. Obviously, this is something that needs to be discussed with the patients, and it is the patient's prerogative. And that's where I feel that the role of non-steroidal anti-inflammatories comes into play, because if the patient decides he doesn't want to get a steroid shot at its initial stages, then that's fine. I do still need to give him something for their pain relief.
Great, thank you.
Thank you.
Dr. Mustafa Kadri has a question. Sir, please unmute.
Ji, Assalamu alaikum, Mustafa. Thank you so much for
Assalamu
this very nice talk, and also demonstrating some of those exercise maneuvers. And I was just wondering if a bowling action like a fast bowler does, would that be one of the exercises you would recommend? Because that's one of the things that personally worked on me a decade back, with something very similar to what sounded like adhesive capsulitis. Required steroid, did not help, and then slowly started my bowling exercises, and then eventually the whole shoulder got released. But is that motion, which is like a rotatory movement at that ball and socket joint, is that something that would be recommended, or that was foolhardy?
No. Well, it's because the challenge is a sports or an athlete is a whole different ball game altogether, and we've got patterns of injuries that we've seen, and there's research on cricketers, especially in the Australian league and Australian cricket players, and we found that it depends on the bowling action as well. So if it's a medium to fast player where they chuck the ball down, that's where the long head of bicep flicks onto their humeral head. That flicking causes inflammation, and when that happens, that could consequently cause adhesive capsulitis. As opposed to a spinner, it's actually the humeral part of the glenohumeral ligament that stretches, and that inflammation causes adhesive capsulitis. So yes, generally the goal being that you either put topical medications or medications before any session, any sporting session. You do your pre-stretches, you do your sport, you do your post-stretches, take your medications and carry on. And if this becomes a regular habit, that's pretty much where we are with home-based exercises. But we've got to realize that a sports player is a different ball game from the general population. So you're the elite, Dr. Kadri.
Thank you.
Thank you, Dr. Kadri. So any other questions? No questions?
Sounds like we're done.
Yes.
Yeah.
So, yeah. Do you want to say anything?
I was just going to say thank you very much for the opportunity.
Thank you so much for the lovely talk, Dr. Mustafa. On that note, we just conclude today's grand round. Thank you very much once again, everyone, for joining in. Thank you. Stay safe and goodbye. Allah Hafiz.